بصراحه انا قلت كلمه حق، يعني هو لازم واحد يبقى دمه تقيل معانا، يعني لازم يبقى دمه تقيل، يعني عايز ما تسهلش الامور، لا يعني العمليه الدكتور جمال قال كلمه سهله، هتبقى حاله ايزوتروبيا، لا مش حاله ايزوتروبيا عاديه، هتبقى حاله ايزوتروبيا عاديه، ده مش هيصلح بسهوله ابدا، مش هيصلح بسهوله ابدا، وهيبقى مونوفيكسيتوس مش هيشوف باينوكلر، فدي قصه يعني قريب كده معقده جدا، انك انت تاخد عيان كويس واكوموديتيف وتسهل له الامور، لا انا مع اللي يكسر مقاديف اي حد بيعمل الفكره دي. مالناش دعوه بقى، اللي عايز يكسب يكسب، يعني احنا مش عايزين نكسب فلوس، لكن احنا بنقول كلمه الحق قدام ربنا، دي مش حاله ايزوتروبيا عاديه، العمليه هتكلكع ما هياش حاله. شكرا.
هو الحقيقه انا ببقى متفهمه برضو العيانين دول، نمره واحد معظمهم اتقال لهم ان الايزوتروبيا دي تمبرري وهم صغيرين وهتختفي، فبيبقى عكس التوقعات. ثانيا ان هم بيبقوا فعلا برضو كتير سالوا طب احنا ينفع بعد كده نستغنى عن النضاره على اساس ان الايزوتروبيا هتختفي، وغالبا بيبقى الرد برضو لما يتموا 18 سنه 20 سنه ممكن يبقوا يتعمل لهم ليزر. هي المشكله الاساسيه في الهايبروبيك ليزر عامه الريجريشن، يعني كتير منهم ممكن يبقوا immediately post ليزر يبقوا aligned، بالذات اللي يبقى refractive correction similar للكوركشن اللي هم لابسينه في النضاره، بس هي فكره الريجريشن كلهم young age، وعاده الهايبروبيا ما بتبقاش برضه سمول او مودريت هايبروبيا، فبيحصل لازم يتقال لهم ان هيحصل لهم ريجريشن زيهم زي اي هايبروبيك ليزك، فهيحصل تاني من الاستروبيزمس هيقل، بس هم الحقيقه يعني العيانين دول ببقى مشفقه عليهم. طيب
دكتورة دينا حسام ان شاء الله تكلمنا. اتفضلي.
شكرا للدكتور جمال، الحقيقه موضوع مهم جدا جدا، يعني احنا بنعمل البرنامج لما الدكتور جمال بعت الموضوع ده كنت سعيد جدا. انا الحقيقه عندي خبره كويسه في الايتم ده، لان انا بعمل كتير هايبروبيك ليزر. في شويه يعني في حقائق، الفلاترينج اوف ذا كورنيا بالنسبه للميوبيا في الليزر احسن كتير ونتائجه احسن من الستيبلينج اوف الهايبروبيتروبيا. الحاجه الثانيه الليميت بتاع الهايبروبيتروبيا اكتر من زاويه 3 ما بيصلحوش. يعني بالكثير ما شفتش حاجه يمكن 3.5 بالكثير عشان يتصلح. فزي ما حضرتك قلت في معظم الحالات الاكوموليتيف ايزوتروبيا اللي هم زائد 3 او اقل، نسبه نجاح الليزر فيهم ويتحسنوا الايزوتروبيا كويسه جدا. اللي بعد كده فيها كلام كتير مش هيتصلح. والحاجه الثانيه لما بنيجي نعمل ليزك في الهايبروبيتروب ما بندخلش الريفراكشن الحقيقي بتاع العيان ده، مثلا زائد 3 انا بدخله 4 بيجيب النتيجه كويسه، لو دخلته 3 ما بيجيبش نتيجه كويسه. فهو لازم الواحد يبقى يعني اونست مع البيشنت وما يعملش البحر طحينه زي ما بنقول، يعني كل حاجه تمام وتعمل العمليه. لما بيكون عندنا حالات كتير زائد 5 وزائد 6 استحاله هيقلع النضاره. ممكن اقول له هنعمل لو حد يعمل ليزك يخف من استخدام النضاره قليلا، ولكن بتقابله مشكله ثانيه ان يبقى عنده سمول انجل ايزوتروب. فهي يعني عايزه فيري هاي بيشنت سelection.
دكتور ابراهيم، وانا يعني حابه ابتدي بان انا اشكر دكتور ابراهيم الحقيقه ودكتوره منال على المجهود الرائع اللي بيعملوه، وعلى التجميع الجميله اللي بيجمعونا فيها كل سنه، بيبقى مؤتمر حقيقي مميز وفيه روح كده من الالفه مختلفه. انا هتكلم على موضوع بسيط خفيف، الاكيوت اكوايرد كوميتنت ايزوتروبيا، والحقيقه recently يعني the number of cases we see has been reported globally ان هو زايد، و it was attributed mainly to the increased usage of digital devices, especially بعد اللوكداون of the COVID-19 pandemic. في overlap واضح بين ال acute acquired comitant esotropia وال acquired non-accommodative ET، و attributed برضه mainly لل difficulty in determining the true acute nature of many cases of AACE. Acquired non-accommodative ET is by definition a non-accommodative ESO-deviation when not corrected when wearing the hyperopic glasses by more than 10 prism diopters. الكلاسيك classification بتاعت ال AACC by Varian and Miller قديمة في 1958 they classified the cases into 3 main the SWAN type, which is caused by the interruption of fusion. Type 2, or the Franceschetti type, which is mainly triggered by physical and psychological stress. And the type 3, or Bilshevsky type, caused by myopia. بس الحقيقة ظهر many more classifications based على الاكسبيرينس بتاعت الاوثرز. في classification كانت قسمتهم ل 7 subtypes بس they did not include any myopic cases وما كانش فيها الديجيتال device related cases. يمكن عشان دي كانت قديمة شوية أكتر من 10 سنين. في تانية classification into 2 main subgroups, mainly on the angle, small angle versus large angle. I will go through يعني co-specific types related to date of different types of AACE. So the first type, or the SWAN type, is the esotropia that develops after interruption of fusion, and it's an acute ET, usually develops بعد monocular occlusion, and also vision in one eye, whether due to a disease or injury, where it's postulated in هي due to the interruption of fusion, even though بس for a short time occlusion, particularly في الحالات اللي بيبقى عندها weak sensory fusion. كل الحالات in the SWAN type are reported to be hyperopic. A second entity is the decompensated monofixation syndrome, which we usually see in cases whether in previously treated strabismus, anisometropes, unilateral macular lesions, وفي بتبقى حالات idiopathic أو primary. By definition, the monofixation syndrome is a microtropia, no more than 8 prism diopters, with good fusion divergence amplitudes, usually large forias on alternate prism cover test. They have a measurement stereopsis, but usually not better than 60 arc seconds, and it's a very, very resistant form to be treated out to convert into bifoveation. A monofixation syndrome may remain unchanged in many patients throughout their life, بس بيحصل لبعض الحالات decompensation where they lose their fusion and amplitudes. في study, it was a 3.5 prospective study that reported that the most common etiology of AACE was decompensation of monofixation syndrome or a pre-existing phoria. We're also aware of another type called cyclic esotropia, which are alternating intervals of esotropia and orthotropia. It's mostly idiopathic mechanism لغاية دلوقتي لسه مش well understood, usually occurring in 48-hour cycle, as برضه other patterns are reported. The ET that also we see recently more is that develops only at distance in older adults, sometimes referred to as divergence paralysis. It's a progressive, usually ET at distance with a slight or no esotropia in near vision, usually after 50 years of age, without any neurological disease. It's postulated to be a divergence paralysis type of a sagging eye syndrome due to the age-related changes in the orbital pulley system. This is the hot topic to date, which is the ET after prolonged near work, or the digital device-related AACE, which recently received more attention. And some speculate that actually uncorrected myopia is a consequence of the ET rather than a pathogenic mechanism, because those patients with myopic ET are more likely to maintain esophoria because they can see clearly without the refractive correction than with the correction for near. In children, usually the angle tends to be larger, and there's definitely a relation of the number of hours and the working distance with the development of AACC. They compared in a famous study 62 AACE patients with 73 orthotropic controls. They found that they work within a 50 centimeter distance for more than 8 hours a day. In more than 3 months, it was in 57% in the esotropic patients and only in 10% in the control group, and the excessive close visual activities and long hours are definitely risk factors. The mechanism is not yet clearly understood. It could be an imbalance between the convergence and the divergence because of the excessive near work increases the tonus in the medial rectus muscle, resulting in the development of the esotropia or weak divergence. The excessive accommodation is another theory, with the shorter viewing distance requires greater accommodation that can trigger the excessive convergence. Basically it messes up the ACE ACE ratio, and another one is the convergence spasm due to the overcorrection in myopia in some cases. And we're all aware of the 20-20-20 rule. We advise always the patients or anyone who has excessive near work nature that every 20 minutes he should look at something 20 feet away, which is 6 meters away, for 20 seconds to relax the accommodation. The entity of the idiopathic or physical and psychological stress-related ET, which was specified as the Franceschetti type, patients usually have a minimal amount of hyperopia in this entity and a relatively large angle of deviation. It should be noted that this is a diagnosis of exclusion because it's very important to differentiate it from the ET caused by serious neurological condition. And AACE could be the first sign of an intracranial disease, whether hydrocephalus, tumors, or meningitis or demyelination. And actually, previous reports confirm that all those cases had no signs of adducens nerve palsy at the time of initial examination. And this is where it comes from, the debate whether to do imaging for all cases presenting with acute comitant esotropia or not. Of course, if we have symptoms suggestive of a CNS abnormality like nystagmus, headaches, vomiting, or we have an established papilledema, it's indicated. But sometimes the symptoms are not present, and only on imaging study we identify the tumor without any neurological symptoms other than the acute esotropia. We should be also aware that early recurrence and failure to re-establish the binocularity after the strabismus surgery is also a red flag. So we start, of course, by the detailed history, but stressing on the nature of onset of the disease, whether the ET or for distance only, near only, or both, the history of the trauma, the fever, occlusion or any types of stress. We should revise the refractive correction of the patient, and we should also know the nature of the work, how many hours of near work, and also the symptoms of diplopia. The examination, we should examine the deviation for distance and near, and it's very important to examine the deviation in side gazes to find out if there's any incompetence that it's not evident by the usual primary gaze measurements. Also motility examination, it's very important to elicit any minimal abduction deficit. Stereopsis, we have to exclude papilledema and do the sensory functions with the 4th dot test or the red filter test for diplopia. The refractive correction, of course, is diagnostic for accommodative esotropia, and overcorrection or undercorrection of myopia is also corrected because it may affect the alignment, and we know that brain imaging if a neurological cause is suspected. All patients are advised to reduce near work. In some cases, it works and improves the condition, and it's not yet clear which cases will respond and which will not, but we face those children in which the reduction of the digital device use affects them and improve their condition. Non-surgical treatment includes the prism therapy using a bilateral base-out prism to reduce diplopia. The most recent, and there are many reports using the prisms as active treatment. They gradually reduce the Fresnel prism power, which can be fused at near but has a slight diplopia for distance, to stimulate the divergence power, and they wean off the patient from the Fresnel prism till they can be taken off. The topical cycloplegia, actually it's questionable. Sometimes it works, maybe in cases with an abnormal ACE ratio, but most studies actually did not specify the refractive values before and after cycloplegics prior to treatment. The Botox, actually there's also no certainty of evidence whether it may be an alternative to surgery, actually as an independent treatment modality in general in acquired ET in children. So we're left with the strabismus surgery, which is actually the common, highly effective traditional treatment for the acute esotropia. There's no consensus on the choice of surgical technique, whether by medial recession or resect or the surgical dosages. Although recently many reports recommend the medial recession, but most of them are not head-to-head comparative studies, including small number of cases. Also, augmenting the surgical dose of AACC is more or less a common consensus by 1 to 2 millimeter, because most studies found out that surgery based on the standard surgical table for this entity often results in undercorrection. A very useful method is to reveal the total angle of ET using either the short-term prism adaptation test, which has been proven to provide better binocular vision and fewer recurrences, or a more simple alternative is doing the test of monocular occlusion at office for 45 minutes, the same as we do for the intermittent XT patient, and this has been also reported that it can detect latent deviation in ET. So to conclude, there's a recent increase in digital device-related AACC. It has been recognized when we all see those patients recently more often. It's assumed to be triggered by new work, monocular occlusion, inappropriate refractive correction, and physical and psychological stress, but some cases are accompanied by life-threatening intracranial disease, so these cases should not be overlooked. And thank you.